So here's some guidelines, examination guidelines. The tests that you use are influenced by the history of the observation, like you said before. So you start off and do things in that order because what you do first will drive the rest of the assessment. There is no need to do ankle tests if it's a shoulder injury. I think that's pretty obvious. How do you know it's a shoulder injury? Because you ask them in the history. Get the information from the history, determine what you need to do next based on the information that you received. And then take a step forward, do your range of motion, pick up on things in range of motion specific to what you got in history and observations. And then your special tests are based on everything else before that. Other guidelines, patient position you have to be aware of. If you look at McGee's book, in the back, there's something called, I really don't know how to say it, so I apologize, but it's called spreadsheet. I don't know if the accent's there or there, but there's an accent there somewhere. But it gives you a guideline with how to minimize excessive patient movement. If someone's hurt, the last thing you want to do is have them flip around, jump up and down, and get on the table, off the table, back on the table, flip onto their stomach, flip onto their back, way too many times. In the winter, Mara will show you how to refine your assessment so that you don't have to do it that much, and so that you can keep patient comfort as a top priority. You can look at that now. That's not the expectation for this semester, though. That's more advanced. So those of you who feel comfortable with your assessment, maybe start looking at that section to see how you can refine your assessment process. Okay. Therapist positioning. How many of you massaged somebody before? You guys know what how long a massage therapist lasts in their field? They don't last very long. Why? It's very tiring. It's very tiring. To do 1 hour massage treatments 6, 7 times a day, it is so tiring. For some of you that might have transverse friction or trigger point massage, your fingers get tired, and you're only doing that for like 5-10 minutes. But to do it for 60 minutes and then do it again and again and again, it gets really tiring. So we try to emphasize certain body positions when you do certain tests, again, so it's easier on yourself as well. If it's easy on you, your tests will be far more reliable. Okay, so we'll give you some pointers with how you position yourself when you do these types of tests. Hand position is as well as important. I'm not really strict on hand position because there's many ways to do things. Again, you have to look at the mechanics or the kinematics, let's say for a joint, in how you move the bones to stress that tissue. Now, where you put your hands, to me, it doesn't really matter, as long as you're stressing the tissue. And if you know what a KT1000 is for ACLs, it's a little torture-looking device. You put your leg in it, and you actually pull this pole, and there's a little meter on the side that says how much anterior translation of tibia there is. You're not even using your hand; you're just pulling on this thing, but your quad and your thigh is strapped down to the other part of this contraption. So are you really doing a lockbends? Absolutely, because you're moving the tibia away from the femur at 30 degrees of flexion. I don't care where you put your hands. I don't care what position the patient is in. Can you do a lockbends with the person face down? It's called a reverse lockbends. Different way to do it. Is there a potential situation where you'd have to do a lockbends with someone on their face down? If there is, now you know how to do it. Okay. At the end of the day, in that, so you take a regular lockbends and a reverse lockbends, hand positions can be a little different, but you're still stressing the tissue the same way. And that's what you need to realize. Normal side first. The reason, you want to prepare them. You don't want to take an injured joint and go, bam, because they'll jump. Okay, so usually the best one instruction you can use is, this is what I'm going to do on this side, just this is what it feels like, this is what it normally feels like. So let me know if it feels any different. Are you okay with that? And then go ahead and do it on the injured side. Known non-painful movements first. Leave this stuff to the very last. If you irritate things initially, you won't be able to rule out other things. Okay, so this is tricky. Don't focus on this yet. Okay. So let's say, for example, for the knee, there's flexion, extension, internal, external rotation. If you know internal rotation is going to be painful for the lateral side of the joint, let's say, keep that in mind. Do it last. Let's do flexion, extension. Maybe let's do flexion first, then external rotation, and then extension, and then internal rotation. Okay, so whatever movements you think, you predict might be painful, try to save those last. Now, what you'll probably do, it's just from what I've seen in the past, and it's just because the grading sheet is set up this way. Flexion, extension, internal rotation, external rotation, abduction, adduction. People always group those together. Now you can do, some people do this last and that second, but they're always paired. In some situations, the ideal thing to do, depending on the injury, you might want to do flexion first, maybe internal rotation next, maybe abduction next, maybe extension, maybe adduction, and then maybe external rotation last. And that's okay if you do it in different order. If your rationale is, these three are expected to be painful, so I'm going to save those. Now, if you try to do that now, you might get confused. So, we're okay with you doing it in that fashion. Even though, okay, that one, oh, that hurts, oh, that hurts. That's fine. Okay? But keep that in mind, because you need to use that same idea when you do special testing. Okay, whatever your first round draft pick is for injuries, you want to test that last. Rule out the other two first, and then confirm your first indices with that special test last. Okay. So if you say, I really do think your injury is an ACL, it might also be an MCL, and it might be a meniscus, I'm not sure. Test this first, test that second, save this. Oops. That's a 3. Save that for last. Does that make sense though? Okay. Which also I want to remind you to state your indices so that we know to do that. We know to check you on that. Okay, state it right before your special testing section so that we know that we're looking for you to test this one first, that one second, that one last. Okay. And last but not least, how patient is last. Scanning, any questions so far? So that was just general guidelines. So for scanning and clearing, the difference between the two. We mentioned it briefly before. You have your chronic injuries and you have your acute injuries. And for the chronic injuries, pain can come from anywhere. So if you think after history, you're pretty convinced it's a chronic injury, or if there's any other indications, specifically neurological, then you have to do a scanning exam. Insidious onset, something that's not specific or diffuse, I don't know where the pain is. It's just that whole area is sore. Then you might want to think about doing a scanning exam. Radicular signs, so numbing and tingling, change of sensation, spinal cord signs and symptoms, or several joints or body parts are involved. That is your list of indications to a scanning exam. If you see any of these things, you have to assess the entire, what we call a quadrant. If you cut yourself into 4 quadrants, my right lower quadrant is everything from here down. Everything. Lumbar spine, pelvis, which is your SI joint, hip, knee, ankle, foot, and toes. Plus dermatomes, myotomes, and reflexes. It's a little bit more involved. It takes more time. Okay. So if you see any of these things, you assess the quadrant, the whole thing. If somebody says, no, I heard it yesterday, I know exactly where it is, and there's no numbing and tingling, all you need to do are the joints above and below. If it's the knee, just do the hip and just do the ankle. Okay, and when I say do the quadrant or do the hip and the ankle, I'm referring to active range of motion and passive range of motion. There's still debate whether you need to do resisted range of motion as well. So if you have time, do it. At the very least, you're ruling out the joint above from joint below by doing active and passive resisted range of motion. We'll get to what that is in a second. So here's an example. Patient comes in reporting with knee problems. During the history, you learn that the symptoms are often not just in the knee, but in the anterior thigh and lower leg, as well as it is occasionally tingly. You elect to perform a scanning exam. What parts of this tell you scanning? What's one? Somebody on this side. Just not in the knee. What else? Tingly, perfect. And there's many more. Okay? There's one of them on that list, just do a scanning exam. Step 1, lumbar spine range of motion for lower quadrant injuries. So lumbar spine. Flexion, extension, left side flexion, right side flexion, left rotation, right rotation, active, passive, and again, there's debate about resisted. Generally, the idea in the first semester is do everything. And then Merrill will tell you, and Mark will tell you when they teach you in the winter, you can cut things out like this. Okay. So that's lumbar spine. As soon as you're done with the lumbar spine, and someone can say quadrant, you do a peripheral joint scan. We'll talk about the quick test in a second, but you have to test the sacrum, because that's a joint, your SI joint, hip flexion, extension, all those other movements, knee range of motion, ankle range of motion, toe range of motion. The reason why that's there is because you know how we said we have to do dermatomes, myotomes, and reflexes? There's overlap. You do not have to do it twice. Once you do hip flexion, L2 is done. If you know what L2 is. Okay, so you need to know your dermatomes, myotomes, and reflexes as well. Okay. Now this said think ahead for myotomes. I'll just give you a hint for next semester. Think ahead for other tests as well. Okay. So for example, active straight leg raise is a special test. If you have them do hip flexion as part of your scanning, you've checked off L2 myotome, and you've also checked off active straight leg raise as a special test. So one movement clears 3 things. Okay, so you can do that. You're not expected to do that now, but again, I don't know where everybody is. But if you feel comfortable doing that, by all means. So after you do your spine for the lower quadrant, you do the peripheral joint scan as well. Step 3, myotomes. We talked about that before. Do not need to retest those evaluated properly in your strength testing. Look for fatigability and sustained maximum contraction or repeated break test. Okay. So what for resisted range of motion is a break test, and you're looking for fatigability. So is the nerve firing constantly? Okay. So you hold the joint at mid-range. You say hold your limb there, don't let me move you, and you just push. If they can hold it there, I think it's about 5 to 6 seconds you got to hold it for. And usually people with central nervous system issues, with neuromuscular issues, they won't be able to hold it. It'll just release. They won't be able to hold it. So that's what you're looking for if it's neurological. And again, take care of not irritating the injury. Keep that in mind when it comes to hand placements as well. A lot of people sometimes they just want to jump on the special test, so they'll just grab onto whatever, not realizing that that's the lesion site, and so they'll jump. Your patient will jump. Any questions about myotomes for lower body? Again, there's a lot of crossover. For dermatomes, you can test them at the same time, so close your eyes, let me know if it feels the same or feels different, and you just follow the dermatome patterns. Sweeping motions with light touch, hands or tissue. Does this feel the same? Yes or no? Is there a difference? And then state why. This stuff, if you find differences, and if you pick something out of the history, you might have to do further testing. So temperature, pressure, and these are all based on receptors under your skin. Okay, and those are controlled obviously by nerves. And then the last one is reflexes. So there's your deep tendon reflexes, which is your patellas and your Achilles, and there's other ones. And there's your superficial ones, such as the abdominal. And then there's your pathological, Hoffman, Visky, Chaddock, Oppenheim, Clonus. How many of you have done reflex testing before? Okay. Last but not least, step 6 is spinal or peripheral joint assessment. Okay, so based on what you found, should you continue with assessing more specifically, so let's say it was the knee injury, based on all the things you've done with your scanning, should you actually assess more thoroughly the spine? Is it coming from the spine, or is it actually coming from that joint area? But after going through these 5 steps, you should make a decision on which one you need to focus on. Otherwise, if it's not a scanning, it's a clearing. At the very least, we have to do a clearing exam, which means joint above, joint below. Active range of motion with overpressure. Overpressure is also passive range of motion as long as active range of motion is pain-free. Okay. I'll say that one more time. Overpressure is passive range of motion as well, as long as active range of motion is full and pain-free. Okay. Jordan, put your hand up. So if Jordan says, I can lift my hand all the way up, that's active. He says it doesn't hurt. I push further, that's the overpressure, because I'm stressing non-contractile tissues, the joint capsule ligaments, stretching some muscles. But if that was pain-free and the overpressure was pain-free also, I do not have to do full passive range of motion. You don't have to. This last bit, the overpressure, is the same as passive range of motion. Okay? Now, if it's painful, you do passive range of motion from start to finish. In Manitoba, they do about 5 or 6 reps for passive range of motion, which you can as well. And then resistant isometric testing. So in this particular case, the patient comes in reporting of knee pain. If you determine that scanning exam is not necessary to perform a clearing exam, this means active range of motion with overpressure, resisted isometric testing as well of the hip and ankle. Joints is evaluated prior to assessing the knee itself. Okay, so if they complain of knee pain, do the hip and the ankle first, and then focus on the knee after that. Just keep the painful stuff last. If you gain information to suspect structures in the hip and or the ankle, you will adapt your assessment as necessary from this point. So let's say, for example, they came in and complained of knee pain. You know, we saw the anterior tilt, that was tight, that was weak. Well, let's just say that every time they extend, they actually feel a pull up here as well. So you still do the assessment for the knee and the hip. Which one do you think you should start with first? So we just did a clearing exam. We did do ankle and the hip, but they also said when you were doing my hip stuff, it hurt up here a little bit as well. It hurts even more when I kick my knee up. But I felt something up here as well. Think about which one's more painful and save that for the end. Hip first. Okay, so just do the hip first. That hurts a little bit. Find out what hurts, how strong it is, and then do the knee last. Okay, do you have to do the hip more thoroughly? No. Just do active range of motion with overpressure, and then depending what you find, you may or may not have to go more thorough into the ankle hip. Okay. Any questions about scanning and clearing?
Would you do like the joint above and below for trauma?
So that depends as well. So let's say that trauma is mid-forearm. If there's no deformity, you do. I would have you do the wrist and the elbow. If it's obvious, I wouldn't have you do anything. So if you get the history, heard a crack, can't move it, pain hurts, observation, angulated fracture, stop there. Don't even move on to scan angular. Because you know what it is now. But let's say it's non-displaced, closed fracture. They heard a crack, they can move a little bit, so I would assess both joints above and below. Okay, so it's all dependent on the situation. Okay, but again, take information from the previous steps in order to move forward. All good? Okay. You guys are dozing a little bit. Let's take 5 minutes. Take a walk. We'll do reflexes when you get back. We'll start banging each other. Okay? So we'll start in 5 minutes. We'll do reflexes.